to From the Clinic to the Living Room. I am your host, Melissa Wilson. Tonight, our topic is a very popular one. We're talking about ctDNA, so we're going to learn all about that tonight. Our special guest is Dr. Andrew Poklepovic. Or Poklepovic, I'm sorry for pronouncing your name wrong after I practice it. He serves as the assistant professor in the Division of Hematology, Oncology and Palliative Care at VCU Massey Cancer Center. He is a Harrison Endowed Scholar at VCU School of Medicine and is also the medical director for the Massey Cancer Center Clinical Trials Office and the associate member for their Developmental Therapeutics program. So I'm so happy that you're here tonight to talk about ctDNA. I know this is a very hot topic. We get tons of questions through the Ask an Expert line and from our patients in clinic. So welcome and thank you for joining me.
Thanks. Happy to be here.
Awesome. So I guess we'll start out really easy because I just want to kind of get a feel for what is ctDNA. So in your words, what are we looking at when we're talking about ctDNA?
Sure. So ctDNA stands for circulating tumor DNA. So it is actually fragments of cancerous DNA that are breakdown products of tumor cells that have died that you can detect in the blood with highly specialized tests, typically PCR tests designed to capture those specific mutations. And it gives you a resolution of microscopic levels of cancer in the body.
So I want to, just before we even start, because you said something very important. So these are ctDNA fragments that are dead. So like a lot of times patients will ask this question. I know this isn't on our pre-populated list, but just to clarify, like this doesn't mean that you have live ctDNA that are live cancer cells floating around necessarily, but it does indicate that there is some disease potentially somewhere, correct?
Yeah, so ctDNA is generally shed by tumors because all cells undergo a life and a death process, just the way you shed your skin cells and your mouth cells. As you burn your mouth on hot pizza, it heals in a couple of days. So tumors that exist can shed small amounts of tumor DNA as some of those cells die and are replaced by other cells. And if there is more tumor, larger tumors, it will shed more DNA because there's more of these cells undergoing that process.
That makes total sense. So I guess one of the things is like, how do we perform this test?
Sure. So circulating tumor DNA is a technology that's been around for a number of years, but more recently there's been an advance that makes it much more personalized to individual patients. So all tumors have mutations in them. It's what causes a normal cell to transform from a properly behaving, doing its job cell to a cancer that wants to cause havoc. And those mutations are things that can be picked up and captured by these types of tests. For a very long time, we had a stock set of probes that could measure some of the more common tumor DNA mutations, like a BRAF mutation for melanoma or an NRAS mutation in melanoma. But in order for a person to have a ctDNA test work for them, their cancer had to have that type of mutation or the test would miss it, because the way a PCR probe works is it's very, very, very sensitive, but it has to be an exact lock and key fit. So if you don't have that, it won't capture that. So more recently, they have moved into a new arena, and there is a type of test called tumor-informed ctDNA. There's one company currently on the market that's offering that. The company is Natera, and the assay is called the Signatera assay. The way that works is they take the patient's tumor and they do a complete sequencing of all the genes on the tumor. Then they identify 16 of the most common mutations in that tumor that has been removed from the patient already and create a custom personalized set of 16 PCR probes to really look for a fingerprint of that tumor in the patient's blood as they're undergoing treatment or in a surveillance strategy.
Which makes it completely specific to each patient. That's the one thing that I think is completely
I tell patients this is the most personalized test that has ever been developed in medicine. That blood test will only work for that patient for that cancer. And they create a brand new custom personalized test probe for any patient who undergoes tumor-informed ctDNA monitoring.
So this test is a blood test, correct? I mean, part of it is blood. Obviously, some of it is
Yeah.
tumor that they get from your tissue, but
Yeah, so the way it works is you have a simple blood draw. Rather than being the purple top tubes, it's called a leopard top, it's a Streck tube. It allows the DNA to be stabilized in the blood tube for several days, and then which point that blood, after it's drawn at the time that routine labs are being drawn, gets shipped to the processing facility for Natera, and it's run, and then you get your results back in about a week.
it's so fast. It is so fast. So, what kind of, I know you touched on this a little bit with, the signature, but what kind of information can be gathered from this test? I think that's super important.
Yeah, so what it does is it gives you a numerical value. 0 if it detects no DNA, and then it gives you a result in something called MTMs, or the mean tumor molecules per milliliter of blood. And what you can use that for is to see if a patient is responding to a treatment, even if the scans are too soon to be drawn or haven't told you, if you can't tell, maybe this is bigger, maybe this is smaller, is this person responding? If the tumor DNA is rising, there's more cancer and there's more detection of that. And if the tumor DNA is falling, then those patients are having a response and an anti-cancer treatment effect. In the surveillance state, this is being done commonly in colon cancer, and it's starting to be explored more in other tumors like kidney cancer, bladder cancer, as well as melanoma. Patients who can be monitored while in remission to see if their tumor DNA stays at 0 or if it's perhaps rising, potentially suggestive of an early relapse.
Okay. So this could be a really useful tool, especially in folks that, that we're not really sure when to stop immunotherapy. Is it 2 years? Is it 1 year? Is it 6 months? Is it 8 months? If we see that ctDNA go down to 0, really you technically could consider stopping.
Yeah,
Right?
so the Signatera assay was studied in patients receiving PD-1 immunotherapy. So in melanoma, that would be pembrolizumab or Keytruda, or Opdivo or nivolumab monotherapy. And patients who had declining ctDNAs while they were on treatment had better survival than patients who had rising ctDNAs. If somebody had rising ctDNAs early on in their treatment course, it was associated with progression if the scans looked like they were getting worse. In melanoma, there's this thing called pseudoprogression, where sometimes the tumor looks like it's getting worse before it actually gets better. And it's a big clinical dilemma. Is it getting worse? Is it getting better? How do we know? And in that study, patients who had tumors enlarging at the same time as the ctDNA was rising, they all ended up with progression, and no one had the pseudoprogression. But remarkably, the patients who had detectable ctDNA, say a value of 10 or 30 or 50 or something even higher, if they cleared all of their ctDNA, all of those patients became long-term survivors. So it does allow you the potential for using this information as you're working with a patient who may be having a side effect or really struggling with continuing treatment, to say, well, your ctDNA, you've had stage 4 disease, you've been on treatment, you're doing really well, your ctDNA is now cleared, you're really likely to do well. Maybe we can talk about treatment de-intensification.
I think that's going to be such a useful tool. And what do you see as the limitation at this point for using ctDNA for this purpose? Do you see any limitations in terms of
So there
interpretation?
are probably very, very, very small amounts of cancer that are not necessarily captured on ctDNA. So it's more sensitive. It appears from the studies that they've done, it's more sensitive than just CT scans. And in colon cancer, where most of the remission data is from, it actually preceded a scan showing relapse by 6 to 8 months. So could there be a small enough amount of tumor hiding in the body somewhere that your ctDNA will show up as zeros, but 6 months later, you'll start to see a value climb? It may be. This is sort of in the patients in remission, and there are larger assessments ongoing for that. For patients with metastatic disease, this is a test that's currently being covered, and it allows for a patient to intensify treatment if their numbers are going up. or de-intensify treatment if their numbers are going down. And I'd love to see this be expanded to patients with earlier stage disease. Who needs treatment for stage 2B and 2C? Many of those patients won't relapse, but some will. Who do you treat and who do you not treat? Do you need to treat for an entire year? Could you find the right people that could be stopped early? Could you find the right people that actually need more at the end of that year? There's all sorts of questions about really custom tailoring somebody's treatments based upon these numeric values. And what a patient gets is a report every time it's drawn, every 6 to 12 weeks in general, that shows what their graph has done over time. Values declined, stayed low, or they started low and are starting to rise now. And it really makes it easy to understand from a patient side those
Sure.
numbers in that graph line.
Sure. So you've touched upon a lot of things about how we can use this in the future for melanoma. And I think one of the biggest arenas that, you and I have kind of talked about is in an adjuvant setting, or these folks that have had, bad tumors that have gotten adjuvanted treatment or not, kind of following them for that minimal disease reoccurrence. I think that is an area that we could for sure study right now. Like, we need that right now.
Yeah, and I think it's really important. And so we can take from that an example that was done in bladder cancer. So they did a prospective trial of adjuvant immunotherapy in patients that had bladder cancer that was removed by surgery. And the overall study was negative. The immunotherapy did not appear to make a difference. But many of those patients were never destined to relapse. Okay. So then they looked as part of a pre-specified endpoint, so something they knew they wanted to look at. They said, well, what about patients that had detectable tumor DNA? Did immune therapy make a difference in outcomes in the highest risk group? Sort of that selection of the high risk group of patients. And it did. And it cut the risk of relapse by a third. And then that's a big deal for those that were, at highest risk of relapse. And so, what I'd really like to see is that we get a large enough data set so that we can understand, what does a ctDNA at 3 months after surgery tell you about long-term outcomes? What does it at 6 months tell you about long-term outcomes? How do we incorporate that into surveillance? Can we at some point in the future reduce the amount of scans and ionizing radiation that we have to expose patients to, and just have it be a simple, straightforward blood draw when they come to their doctor's office? There's time to go before we get there, but those are certainly all things that you can envision being on the horizon in the future, and the field moves quickly.
God, this is such an amazing tool to be able to use, especially for clinicians and patients alike. I mean, God, if I could tell people that they wouldn't need to get scans every 3 months, I think some of them would jump for joy. So I guess one thing I want to do is sort of pause for 1 second to tell, the listeners that please now start typing in your questions, because I want to make sure that we get all of your questions answered, certainly. But I just wanted to do kind of a really quick summary, because like I said, I think, this is such an important tool. So ctDNA, it's actually detecting DNA fragments that are found that are specific to the patient, from a signature that is made from your tumor. It's something that can be monitored by a blood test every few months. We can actually look at trends to tell whether or not you're responding to treatment or not responding to treatment, or if your tumor is getting, your tumor DNA quantification is less or more. So this is an extremely good tool to use overall. I think one of the things that I want to stress is that, while this is approved in metastatic disease, it is not approved for disease monitoring at this point yet. And that's one thing, you just touched on, that we, need some clinical trials and things like that to hopefully be able to make that happen in the future. Anything else you want to add in summary before we handle some of these tough questions?
Yeah, there's a lot of questions. I think that, one of the next advances that we're moving to in medicine globally is minimally invasive diagnostics and truly personalized diagnostics.
Mm-hmm.
In addition to tracking the cancer that you already have with tumor-informed ctDNA, there are other emerging blood-based tests that are multi-cancer early detection screens that can help find cancers in earlier stages, increasing the probability for cure. And I think that we're really going to see a lot of movement in this space. This is a brand new arena in terms of the broad-based applicability of it for patients. And I've been doing this. I've got over 100 patients under monitoring with Signatera. And it's been something that has really been embraced by patients. They like that it's for them. They like that it helps them make a decision. I've had a patient who had a bad side effect from immunotherapy after just a couple of doses for stage 4 disease. They were having a good objective response and they were scared to go back to treatment. And so we checked the tumor DNA and we opted to pursue surveillance, and not do any further therapy. And they went into complete remission. The tumor DNA has now been negative for over a year. And we didn't have to go back and risk further side effects because we had that additional piece of information. No piece of data is the definitive answer,
right?
But it can certainly add extra context and layer on top of what you're already doing to help you make the best decision as a team.
Yeah, exactly. We tell patients in our clinic that all the time. We're like, this is just an extra added layer of decision making that's going to help us make tough decisions for you. And we are really trying hard to get this on every single patient we start on immunotherapy. So this is something that I think is going to be hopefully more mainstreamed in the future. All right, Andrew, let's tackle these questions because there's a bunch of things. So John asks, do you need a minimum tumor size to identify the DNA for the liquid biopsy? So I think he's asking, like, could you take off a T3A, like 3 millimeter, whatever, melanoma from your back and use that as your Signatera?
Yes. So from a primary melanoma, in general, the answer is yes. Certainly, if you've got a tumor that's over 1 millimeter in thickness, there's plenty of material. They can sequence more with less all the time. So the amount of material that you need can get smaller and smaller. There are a couple of instances where they struggle to actually have enough material. Usually it's in the metastatic setting where somebody has a difficult to access tumor. They do a biopsy, a needle biopsy of it, and the tumor is very necrotic or full of dead cells because you can't run the analysis on dead material. You need tumor cells that you can sequence. So there needs to be a minimum amount of tumor cells present, but it can be done even on thin primary melanomas.
Okay, that's good. So Eleanor, that actually kind of answers your question too. What if a tumor is not accessible? If they have a primary or they're even a fine needle aspiration or core biopsy that they can get some extra tissue, like that can certainly help. We have this is a question from Will. For someone who's using the Signatera test as I am, is there a way to share data with AIM or Dr.
I'm always interested in people's providers reaching out. We're all in this together. There's one team, there's one fight. It's against cancer.
Great.
In terms of individual patient numbers, there comes a consent sort of thing that makes a single person's contribution more complicated.
Sure.
But if you're with a provider that uses this regularly and they'd like to reach out and we put together an IRB document and can go through it in the right channels, that would be fine.
Yeah, I think, and from my standpoint, Will, like, for me to answer questions about your ctDNA, like going up or down or whatever the case may be, there's so many other factors that we kind of look at, including scans and things like that. So I'm not sure that I'm necessarily the right person to interpret your results, but certainly I can answer questions for you for sure. Okay, let's see. What else do we have here? So Heather asks, is there any significance to the starting number of the ctDNA, for example, 200 versus 50? How high can that number go? She goes on to mention that her doctor says the number is arbitrary and we just monitor up and down. So, like, is it bad if your number's 3,000 versus if it's 50?
It seems to be correlated with the burden of disease.
Yeah. So
I've had patients in the multiple thousands. I've had patients that went from 2 to 102 to 5,000, and their tumor demonstrated explosive growth at that time. So there probably is an association. Could it be that somebody's individual mutations really easily captured and they're collecting it, and maybe it's an arbitrary value? Possibly so. What we know of is where that person's change is in relationship to where they started, up or down, can determine whether or not they're responding to treatment or not. And then being gone or absent is associated with the best outcomes.
Sure.
Whether somebody starts at 10 and somebody starts at 6, is that a meaningful difference? Is there a meaningful difference between 100 and 6? Maybe between 100 and 6, but not between 10 and 6, I would think.
Sure, I agree.
I did see a question asking about, well, if tumors are dying in response to treatment, and this is coming from dead cells, wouldn't you have more circulating tumor DNA even as the tumor's regressing? So
that was my next question for you.
Perfect.
So
think of it as sort of a continuous shower. And because once the cell is broken down, the tumor DNA is only in circulation for about 24 hours. So whatever event takes place on Monday, if it's leading to tumor cell death, the potential for an increase transiently before it reverted back to what's ongoing in the showering is very, very short-lived. And you're checking these things at 6, 8, or 12-week intervals. And so you're having all this time in between. So if the tumor is big and it's getting smaller, that number will go down from 0.1 to 0.2 because the regression has already taken place, and now you have less overall tumor cells shedding DNA.
That makes total sense to me. Hopefully that makes total sense to everyone else, because I think you described that perfect. Someone else is also asking, can you touch a little bit on how the assay may be affected by synchronous or primaries that happen at the same time?
So that's a tough one, right? Because it is so personalized that the tumor DNA test will only work on one of those cancers, because, every single tumor is as unique as an individual person. And so you can't track 2 tumors with one assay. The company has some difficulty with their computer algorithms understanding synchronous tumors, a tumor 1 and tumor 2, and how those values match up. They're working on that, but right now that's something that, I had somebody today that we started on immunotherapy, and they had 2 tumors, but one was a low risk tumor and one was the high risk tumor. So we're only going to monitor the high risk tumor. Okay. And they're aware of that limitation, because there's a number of patients that have had synchronous cancers. 5% of patients will end up at some point with that second cancer. And so sometimes even at the same time, and certainly in sun damaged skin and melanoma, you can have more than one. So they are actively working on figuring out how to maintain their level of accuracy with multiple samples on one patient. Okay.
Larry asks a good question too. Should the CT scans and ctDNA be performed concurrently or staggered? I don't know if, and Larry, I'm not sure if you mean like we draw them at the same time as your scans, or if you mean draw it a couple weeks before, or if you're talking about like, let's get a CT at 3 months and then at 6 months do ctDNA. So I don't know. Yeah. I know in our clinic, we're primarily doing them at the same time so that we have the data for the CTs and the ctDNA at the same time.
But yeah, so I'll do that as well. And for somebody with metastatic disease undergoing immune therapy, they're going to be getting ctDNA monitoring more frequently than they're getting their scans. They'll probably be getting their scans about every 3 months, but they're having an additional ctDNA test at that 6-week mark. So they're getting it at one set of scans, halfway between, and at the next set of scans. And so I like to get it about a week before they come to see me, same as the scans, because there's that 1 week lead time. And if somebody's coming in to review scans, one of the things that happens in melanoma is it activates the immune system. Well, the immune system is lymph nodes. So sometimes lymph nodes enlarge, and the radiologist is like, lymph nodes are enlarging, can't tell if it's cancer, must be concerned for cancer. And that's a really frightening thing for a patient to read. And, oftentimes, well, we're monitoring these things, you're on treatment, that's a lymph node thing. PET scans may not even work in that area because the lymph nodes might just be active because they're doing their job. But having a ctDNA result coming back showing you that the values are declining to overlay on top of the CT scan result can really help people understand why you're making the clinical decision that you are.
Yeah. So let me see. Some of these questions are getting a little bit personal. So if there is a question that we don't answer, please feel free to reach out to us either by email or myself on the Ask an Expert hotline, because I will be more than happy to get the answer for this. But there is a couple of things that are a little too personal to answer live. So
well, here's one that's pretty interesting. There was a question that somebody had put in: is it possible for a specific marker to wane in expression while the tumor may actually be progressing? That's a really good question.
That's a really good question.
Yeah. And so, as we know, in having had COVID take over the last 2 years, it really makes it easier for people to understand the evolution of an organism. And cancer can be treated the same way. The evolutionary processes are the same, right? You had your original alpha strain, then you had your delta, then you had your Omicron, then you had your Omicron 4, and whatever's coming next. And all of those evolutions have some things that are the same and some things that are different. The
Sure.
PCR test for COVID testing still works for the spike protein because while it's different and can evade the immune system in some ways, it's still similar enough to be captured. And so the way tumor-informed ctDNA works is they apply redundancy to this. So it's not just one mutation like a BRAF or one mutation, like NRAS or something else. They have 16 mutations, and it captures all of those 16 mutations. So one may be fading away as Delta did, and another one may be emerging, but you're not going to lose all 16 the same way you might just lose one. And so that is why they have that redundancy pattern. And then within mutations, there are things in the tree of evolution called truncal and branch mutations. And so as we think about something evolving, and then family trees, as they get further and further away, everybody has some relationship to great 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 grandpa. That's the trunk of your family tree.
Okay.
Now you may have very little in common other than your great 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 grandpa with second cousin twice removed Susie, who's 4 generations later. But that trunk, that foundational person who was those 5 generations ago, is still there. And truncal mutations in cancer stay the same way. And so their algorithm is designed to capture truncal mutations as opposed to the branch mutations, that show up later.
Okay. That's really good information. Do we know, I know that you had touched on that this is covered in stage 4 disease. It's Medicare covered too. Do you know?
Yes.
Okay.
It's being Medicare covered for patients on immunotherapy.
Okay, perfect. Let's see, what else do we have here? I think you answered this earlier. Keith asked if a patient's mutation type makes a difference when using ctDNA as a marker. It's going to make it so specific to their tumor, it shouldn't matter, correct?
Right, and exactly. And they don't actually tell you what those mutations are. So, people who are experiencing cancer and undergoing cancer treatments in the modern era are hearing all sorts of things about genetics. They get a gene panel sent on their test. Oh, you have this mutation, but not that one. We can use this drug, but not that drug. And so having that mutational map of what exists of that tumor at that time can help guide treatment decisions. That's different than what this is. Somebody will still need that for treatment choices, BRAF treatment or no BRAF treatment for melanoma, whether that mutation is present. What this is looking for is a quantity, quantifiable number. Is this collection, is your tumor burden 0, small, large, going up, going down? And that is custom to each person.
Okay. I don't want to get too...
There was a question about capturing tumor cells with a blood draw. So this is not CTCs, that's circulating tumor cells. This is ctDNA, which are much, much, much smaller fragments of DNA that is released from tumor cells. There are ways to capture tumor cells with a blood draw. That's been around as a technique for about 10 years. There's a variety of ways they do that, and there's ways they are trying to explore that, but it's a pretty laborious process, and you end up with small numbers. And it seems now that the technology is really allowing tumor DNA to provide you with much of the same information that you would need faster and easier than tumor cells.
Okay. I think we got all of them. I mean, there's a couple like, oh, here's another one. Da-da-da-da-da. It says for a patient with several years of clear scans, could the test be used instead of additional scans?
And we don't know that yet.
Yeah, it's a
right?
question
And
mark.
so what's going to happen is that we're going to have large scale prospective studies to say, for somebody with negative values, how do they do at year 1, 3, 5, 10? And then we'll know. And then we can say with greater confidence, this is what a negative value year 5 looks like. And some of the trials that are being done in colorectal cancer, serial monitoring matters, how, having multiple negative values. Many of those patients that are being, like, colon cancer is a little further along than we are. They're actually looking at it to figure out who doesn't need chemo after surgery, right, at all. And wouldn't it be great if we can get to that point for prospective trials in melanoma? Who doesn't need treatment? Who can stop early? And those sorts of questions. And in those monitoring situations, in those trials, they're having those things drawn quarterly. Somebody who's been out from treatment for a long time, the likelihood of a big dynamic change in a few weeks is pretty small. With somebody with metastatic disease, 6 weeks can be the difference between feeling well and feeling sick. So
Yeah.
I think that's why they do it so frequently in the metastatic space. And we'll probably see that evolve over time.
Okay. I have one more question and then we have to quit. So, Roger just asked, we have 4 masses on my liver. Would this require 4 separate biopsies? I feel like you've answered this ad nauseum, but I just want to clarify it one more time just so that way we know.
So as long as we're not worried that there's more than one cancer,
right,
one biopsy of the liver with a core needle should be sufficient to generate the probe set through Signatera. Now there's a lag for the very first assay. It's about 4 to 5 weeks for your very first test result. And the reason for that is they have to reach out to the pathology lab, get the slides, have them sent to the lab that is running the test, do the genetic sequencing, then come up with the 16 probes, then devise that patient's personalized thumbprint tumor panel that they're going to run, and then run the results. Sure. So the first one takes about 4 to 5 weeks, can be done on a single biopsy of any one of those lesions, and those 16 probes should be enough to serve as an umbrella to cover all of those tumors, even if they're slightly different from each other. And then within the first 4 to 5 weeks of that biopsy, you could start to get your results. And then subsequent ones are only a week.
Awesome. Andrew, this has been a wonderful webinar. I think we've learned a ton about, ctDNA. I think there's been amazing questions. Again, if there's additional questions after offline, we're always happy to answer them. You and I can collaborate and do some additional testing for those other groups. I would be happy, to be part of that for sure. But I think that ctDNA is going to play a very large part in the future of melanoma and how we interpret things and move forward. So,
yeah, the company is doing a study called the Bespoke IO trial that's available at a number of centers. And that is part of their large-scale monitoring of patients with melanoma getting anti-PD-1 therapy. So that is certainly the company is working on creating the data sets needed to help inform patients and providers for all of these great questions.
That's awesome. Well, I appreciate you spending the time this evening with us, and hopefully we'll see you again very soon. I appreciate it.
Absolutely. Looking forward to it. Thank you all for tuning in.
Yeah, awesome. All right, everyone. See you guys next time.